Thank you very much for coming along today to this workshop. My name's Chris Turnbull. I'm a clinical lecturer in the University of Oxford. I'd like to extend my thanks to Stowood for sponsoring and organising this workshop today. I'm going to talk about sleep studies and how we can get more from our sleep studies than just a number, more than just the AHI. As a way of an outline of my talk, I'm firstly going to talk a little bit about the existing thresholds that we use for diagnosing obstructive sleep apnea and discuss the limitations of these. I'll then move on to discussing newer metrics that we potentially can use to assess the severity of sleep apnea, before illustrating the limitations of our current approaches, particularly with the use of the AHI, with 4 cases. So to start off with, I'm going to talk about the existing thresholds that we use and discuss the limitations of these, particularly in focusing on how the Apnea-Hypopnea Index, or AHI, is not a good predictor of outcome. And many of you will be familiar with the 2 main thresholds we use to categorize our patients, which is the AHI, or Apnea-Hypopnea Index, which is the number of apneas and hypopneas per hour of sleep. And secondly, the ESS, or the Epworth Sleepiness Score, which measures the extent of sleepiness in a number of soporific situations. So arbitrarily, the AHI is cut off into categories, with less than 5 events per hour being described as normal. Individuals who have between 5 and 15 events per hour have mild obstructive sleep apnea. 15 to 30 moderate, and more than 30 events per hour have severe obstructive sleep apnea. When looking at the Epworth Sleepiness Score, scores of less than 10 are categorized as normal, and those of 10 or greater represent excessive sleepiness. But I think, just to put this into some perspective, in the original studies, around 18% of the healthy volunteers, when this was studied, had excessive sleepiness. So really, this exists at quite a high level, even within healthy individuals. And I think it's much more helpful to think of the severity of obstructive sleep apnea as a spectrum, both a spectrum of severity of breathing disorder and of symptoms.
So I think both the severity of sleep disorder breathing and the severity of symptoms along a spectrum. So if you look along the top, you have individuals may have normal breathing through to snoring, maybe only snoring initially in the supine position, but then occurring in the lateral position as this gets more severe, through to upper airways resistance syndrome, intermittent obstructive sleep apnea, and then continual obstructive sleep apnea, which occurs regardless of sleep stage or position. So intermittent might be more dependent on whether you're in REM sleep or in a supine versus lateral position. And likewise with symptoms, individuals can have no symptoms or suffer with symptoms of tiredness and fatigue, through to mild sleepiness and severe sleepiness. Perhaps slightly unfair of me to call that a spectrum, because symptoms of tiredness and fatigue may be more severe than those of mild sleepiness to an individual. But the point I'm trying to get at here is that actually just using a single threshold of the ESS is not helpful, and thinking more about how those symptoms are impacting upon someone's quality of life is much, much more important in making decisions. And there are a number of factors which will influence both the severity of sleep apnea, such as sleep position, and influence how a patient is impacted by symptoms such as shift work, sleep architecture, insomnia, sleep restriction, alcohol, and drugs. If you come back to some of the evidence looking at sleep disordered breathing, actually you can see that the relationship between the AHI and the ESS is pretty poor. So this is going back to the Wisconsin sleep study, which is perhaps the first large-scale epidemiological study to look at sleep apnea prevalence. So it looked at 602 individuals having sleep studies over samples from a community population. So it picked out more people from the general population who are snorers to undergo sleep studies. And it estimated from this the population prevalence of an AHI of above 5. And this was 9% in women and 24% in men. This is back in Wisconsin in America in the 1990s, and has increased since then with increasing obesity. If you add into this whether patients had hypersomnolence, you had a 2% and 4% prevalence of OSA-S. However, when you then look on the Venn diagrams in men and women from the Wisconsin study, you can see that there is a large overlap and not really much agreement between the presence of sleepiness and the presence of a raised AHI. So in men, 15 men had both the raised AHI and hypersomnolence, 82 had just a raised AHI alone, and 20 individuals had sleepiness compared to 235 who didn't have sleepiness. So that's roughly 10% and slightly higher than 10% for those individuals with an AHI of 5 having sleepiness. And this was only just statistically significant for men and not significant for women. And this is a similar diagram to that I showed in my keynote debate, looking at the correlation between the Epworth Sleepiness Score and the AHI, and showing that there really is very little correlation between these two measures. This was both if you score the AHI, let's bring the laser pointer up, by the patient, as shown here on the left, or the AHI scored by the partner, as shown on the right. In more recent epidemiological data, so if you look at the Hypnonaus study, which is a community study in Switzerland, which you may know from showing an incredibly high prevalence of sleep disordered breathing. So 84% of men studied and 61% of women had an AHI above 5, probably because this is using the 2012 criteria for sleep disordered breathing. It was a Swiss population, it wasn't particularly an obese population. But when they looked at the association between the top quartile of AHI in this study and various outcomes, it was correlated with hypertension and diabetes, but there was no correlation between that top quartile of the AHI and sleepiness. Something that I haven't spoken about before, but I think is really important when considering how useful a single night AHI is, to consider the night-to-night variability of obstructive sleep apnea. This is work that we did with Zurich a few years ago now, where we looked at patients withdrawing from CPAP as part of a research study and performing overnight oximetry on 12 nights. So they actually did it they withdrew from CPAP from 14 nights, but we didn't look at the first night in case there was a first night effect. And the last night they were performing an overnight polygraphy. So we didn't look at that night. So looking at nights 2 to 13 of CPAP withdrawal, if you look at the left-hand diagram, you've got the sleep apnea severity based on the lowest ODI, and then on the right, you've got the severity category based on the highest ODI. And what you see is there's huge variation. So from 16 to 62% of patients diagnosed with severe OSA on the basis of one night, if you take the lowest or the highest. And 78% of patients switch severity category over those 14 nights, and 22% didn't. The variability was less. There was an inverse relationship with obesity. So as BMI went up, the variation went down, but that relation was pretty modest. And this is another study where we looked at this in a smaller number of patients, but this is 25 individuals who withdrew from CPAP on 2 separate 4-night occasions as part of a research study. On the first withdrawal, they were all mandated to get into the study to have moderate severe obstructive sleep apnea. And in the second period, we then report showing the prevalence of different severity categories on the right. And what you can see is in the moderate category, actually only 5 of those 13 who initially had moderate OSA on an average of 4 nights of oximetry at the start, only 5 of them had an average of moderate OSA on the second night. So huge variability here. Except some of this will be due to regression to the mean, due to our cutoff for only taking people with moderate OSA when they came in. But just to show that it's not only us who've shown this huge variability in OSA, this is a study from Australia using a monitor which records sleep apnea severity under the pillow. They looked at 67,000 individuals who'd purchased this device and recorded sleep apnea severity long term. They've got 11.6 million data nights from using this device, showing a prevalence of OSA in those people who purchased it of 22.6. If they chose a single night study to diagnose OSA, their misdiagnosis ranged from 20 to 50%, depending on the severity of OSA. And the misdiagnosis rates were lower in patients if they had no OSA or severe OSA. And you can see that here. So 85% of those individuals with no OSA were correctly diagnosed by one night. 77% of those with severe OSA were correctly diagnosed by one night. However, that fell to almost only 50% if you look at mild OSA and moderate OSA. Increasing the number of nights they looked up to 14 nights reduced that variability, but going beyond 14 nights had no further effect. Final slide on variability is this one looking at 3 nights of consecutive polygraphy data, and this is from America. So 10,000 patients who had suspected obstructive sleep apnea who did 3 nights of home polygraphy. And what they showed was that, that there was substantial within patient variability in the AHI. The first night correctly classified patients' severity if you had normal, if you had no sleep disorder breathing in 93%, and in severe, it correctly characterized the OSA in 87%. But this fell to 80% in those with mild to moderate disease. So I think this really just highlights the limitations of using a threshold-based approach and using a single night study. As those of you who came to the keynote talk will know, I think that CPAP works across the severity of OSA spectrum. So I don't think it's that important to know exactly what severity category you're getting. It's more important to know whether there is sleep disorder breathing or not. So this is data from the MERGE study, which is a study looking at giving patients for 3 months either CPAP or standard care, and it was patients who were diagnosed with mild OSA. It included patients who were diagnosed with mild OSA with both on 2007 and 2012 AASM criteria, and in the primary analysis discounted this group who only had mild OSA on 2007 criteria, i.e. had moderate OSA if you use the 2012 criteria. And it showed a significant improvement in energy and vitality with CPAP treatment in all these patients. But when you look at just this group of 95 patients who I'm going to term very mild OSA, i.e. only OSA on the 2012 criteria, what you can see is that they had an almost 4-point reduction in ESS score, improvement in insomnia, and a large reduction in large improvements in the energy and vitality domain of quality of life. So these effect sizes were all comparable to that in the overall trial size. And this diagram is a meta-analysis of studies looking at treating minimally symptomatic obstructive sleep apnea, making the same point that across the severity categories of ODI and AHI, as shown on the x-axis, you have similar improvements in the Epworth sleepiness score with CPAP. This is moving on to say if there are any other ways that we can look at newer metrics to diagnose OSA and help us predict outcomes. So what I've asked in this section is whether any newer techniques of phenotyping might better predict cardiovascular risk than that available to us with an AHI and an ODI. And this has been approached in a few different ways. So patients have been phenotyped on the basis of symptoms and into symptom clusters. So this is data from the Sleep Heart Health study. So looking only at people with moderate or severe OSA and clustering them on the basis of their symptoms, so response to Epworth sleepiness score and a 12-point sleep apnea questionnaire. And what they showed was it was only those with excessive sleepiness who were increased cardiovascular risk compared to individuals without OSA. The other symptom clusters, so minimally symptomatic, moderately sleepy and disturbed sleep categories, didn't have increased cardiovascular risk. And again, this is a slide I showed in my keynote debate. So this is looking at the extent of hypoxia overnight and showing that this is a better predictor than the AHI of cardiovascular disease. So what I mean by the hypoxic burden is the area above the desaturation curve. So this area here highlighted in grey, which is dependent on the length and depth of desaturations. and is also tied to respiratory events. So if a desaturation occurs without a respiratory event, it won't be counted. When you add that up over the night, the individuals in the highest quintile here in purple had markedly increased cardiovascular risk compared to other quintiles. Combining these two approaches together, so looking at this is data from the ERMIS group, so 5,000 patients, 6.5 years of follow-up, patients without cardiovascular disease at baseline, and looking at them, the risk of them having a cardiovascular event over those 6.5 years. What they showed was that in this cohort, the symptoms didn't predict the risk, the AHI didn't predict the risk, but the oximetry did. So the log hypoxic burden or the time less than 90 were predictive of cardiovascular risk. There are two other ways. So we spoke in the keynote debate about using newer metrics or artificial intelligence as ways of trying to get more information out of sleep studies. And there's been a couple of approaches that have been described in the literature in the last few years. So the first is looking at reporting this thing called an odds ratio product. So at the moment, we describe sleep studies in different sleep stages. So we break each 30-second epoch down into whether it's non-REM 1, 2, 3, REM or awake. This instead gives a number, assigns a number to whether an individual is fully awake or fully asleep across 3-second bins, and then averages that across the entire night to give a range from its value of 0, which would be fully asleep, to 2.5, which would be fully awake. They also in this study looked at averaging the respiratory cycle across the whole night. So taking the time, the length of time in inspiration to the length of the total respiratory cycle and averaging that across the entire night as a measure of airflow limitation. And what, if you combine this with hypoxia, you can see is that the extent of airflow limitation and hypoxia predict blood pressure in the daytime, but the overall sleep depth and sleep quality with the odds ratio product doesn't. If you then go on and look at this in multivariate models, the duty cycle, so the amount of airflow limitation, predicts blood pressure when adjusted for variables like age and BMI, and the hypoxic burden predicts blood pressure in individuals not on blood pressure medications. So I think these are things that hopefully in the future will start to be able to move us beyond the AHI. In terms of the first section of the talk, that was all I wanted to say as in terms of an introduction to how we can move beyond the AHI. I wanted now just to run through some cases from sleep reporting that I've been doing recently, where I found it really helpful to be able to listen in and hear the sound channel to get me to the diagnosis. So first thing, starting off with case 1. So this is a 46-year-old man who presented to clinic with loud snoring, witnessed apneas, waking up twice a night approximately to go to the toilet, some choking episodes. So a very suggestive history. He did have some symptoms of restless legs in the evening. His sleep hygiene was reasonably good, getting around 7 or 8 hours in bed a night, and only going to bed a little bit later at weekends than compared to weekdays. He was really very sleepy, however, and this was having a significant impact upon him. He was falling asleep easily in the daytime and was using avoidance strategies to try and stop himself from falling asleep whilst driving. In terms of examination, his BMI was 31, his Mallampati score was 2. So no particular oropharyngeal crowding, and he has a BMI which would mark him about as being obese, but it's not particularly high in our patient population. So he went on to have a sleep study, and it was an adequate, technically adequate study with good hours of recordings and satisfactory signals in all channels. And this was the result in terms of the numbers. So he had a normal ODI, a normal AHI, and normal mean saturations. However, when you then start to look at his oximetry tracing overnight, you get the impression that this is not all entirely normal. So this is his 8-hour oximetry tracing overnight. And what you can see is saturations are nice and flat and stable, probably as he's drifting off to sleep. When he does get to sleep, there are clear small oscillations. They're not typically typical and diagnostic of obstructive sleep apnea, but it's not an entirely normal oximetry tracing. And next, I'm just going to see if I can play this video so you can have a listen to his sleep study in a bit more detail. This one's on the quieter side. Okay, so what I hope you can appreciate from that is that he has obstructive snoring throughout these respiratory events. And what you can see on the tracings is that there's clear reduction in airflow and clear inspiratory flow limitation across this section here. He then wakes up, has a microarousal, so there's increase in ventilation, body movement, and sound at that point in time. And there's an associated rise in the pulse rate to an autonomic arousal. His pulse oximetry tracing is pretty flat throughout this. So this, I think, is a trace where you've got recurrent respiratory effort-related arousals, which this gentleman had throughout the night. And therefore, I think this gentleman has a diagnosis of upper airways resistance syndrome. If you were to do this with a PSG, you might even term this mild OSA. And he's gone on to have CPAP and is trialing that at the moment as we speak. I'm just zooming in now in a bit more detail here to show you a 5-minute tracing from his polygraphy. You can see this event here is classified as an apnea, although there is a little bit of effort there, so it's a hypopnea. And again, another one of these events is characterized as a hypopnea here. So, oh, thank you. So I have to switch it off to play the video. So you can see here that you've got an apnea. This has been termed an apnea and a hypopnea here. But many of the other events which are associated with reduction in flow and heart rate arousals are not picked up as a hypopnea or an apnea there. Okay. And this is just zooming in on one of the hypopneas to show you in more detail in a 1-minute section to show you that occurring there. Moving on to the second case. This is a 74-year-old man who, again, has a history of snoring, but this time the history is not habitual. So he only thinks that this occurs on occasion. And he does have a bed partner, but they've not witnessed any apneas. He has, however, occasionally woken up gasping for breath at night. He only sleeps for around 5 or 6 hours a night. And he can nap in the afternoons, but isn't troubled by sleepiness at other times, and rates his Epworth sleepiness score as 6 out of 24. He has a significant past medical history, so he's got heart failure with a reduced ejection fraction of 20%, hypertension and peripheral vascular disease. And he was actually referred to us as a preoperative screening patient, so he's awaiting colorectal cancer surgery. His initial sleep study showed an ODI of 16, an AHI of 13, and mean saturations of 94. He had a good tracing with 5.5 hours of study, but unfortunately he'd forgotten to push the microphone properly in. So it became a difficult study to interpret because we didn't have sound. So looking at his oximetry alone, you can see that there are clear desaturations. And here you might say that these look somewhat sawtoothed and somewhat typical of obstructive sleep apnea. But later on in the night, they might be a bit more sinusoidal and more typical of a central sleep apnea picture. So we're not certain yet from this. Looking then into his sleep study, we can see clear apneas and hypopneas. So on this slide, I've just got a 5-minute tracing here. So you see a hypopnea marked out here nicely, associated with a desaturation. You can see then following on from that, there's an apnea with a cessation of airflow, heart rate rise, and a desaturation in association. In terms of plethysmography, you can see from its pulse waveform that there isn't really a huge change around arousal here. So it's not particularly helpful in this instance. You can sometimes see respiratory artifacts across plethysmography to try and help you work out whether this is central or obstructive. But I think in his case, the pleth signal is pretty flat and not very helpful. So then we had the question as to what we do next with this gentleman. And the options for us would be to either get him in and do, and our preference would be in this case to get him in and do an in-lab polygraphy, because that would give us control of the signals, but also it would enable us to record the pulse transit time, which we find quite a helpful marker of arousal and upper airway obstruction. So I'm just going to talk a little bit about how we use pulse transit time in our sleep studies, and how I find it helpful. So pulse transit time is essentially the inversely related to blood pressure. It's the time from the cardiac contraction, so the R wave, the cardiac cycle, to the time that the pulse arrives peripherally. And when blood pressure increases, that time decreases. So an arousal causing an elevation in blood pressure will decrease the pulse transit time. And furthermore, you also get changes in the pulse transit time, or the size of a pulse transit time swing, with upper airway obstruction. You get that because during inspiration, there's an increase in intrathoracic pressure, which reduces cardiac stroke volume and lowers blood pressure. And that increases the PTT swing. And so as you have increasing upper airway obstruction, you will have increasingly large pulse transit time swings, which anyone who came to the keynote debate will have seen in Prof Pépin's talk. He spoke about pulse transit time. And this is a slide really showing the point that I was making, that the pulse transit time is time from the ECG to the pulse wave, from the R wave to the midpoint of the pulse wave form. And this is a study from how this is used in pediatric populations, where obviously doing less detailed sleep studies is pragmatically quite appealing. So this is a study where they looked at pediatric patients with suspected obstructive sleep apnea and measured their pulse transit time in patients with OSA, upper airways resistance syndrome, snoring, and normal. And what you can see is that there were increases in the pulse transit time in terms of the size of the swings. So that's the amount of obstruction that you're getting in the upper airways syndrome and the OSA, but also that there was a change in the pulse transit time index. So that's the number of arousals you're getting per hour of sleep. And they were able to get a reasonable sensitivity and specificity based on both of these. So if you take the size of PTT swings, you can get a sensitivity and specificity for OSA, upper airways resistance syndrome diagnosis of 80% and 79% respectively. And if you use the arousal index, you have a sensitivity of 85%, but a specificity of 38%, sorry, perhaps reflecting the fact that it's picking up arousals which might be occurring for non-sleep disorder breathing reasons. And when we do this this is from another patient sleep study, you can see the PTT signal here across the bottom in someone with pretty typical obstructive sleep apnea. So you can see large desaturations. What you can see if I home in on the PTT signal is that you've got small amplitude swings at the start of an event. And as the event carries on, the obstructive event carries on, the PTT swings get larger. You then have this stepwise change in the PTT signal when the patient arouses, and that occurs time and time again. So that's one way that we would often try and diagnose and distinguish between central and obstructive sleep apnea, because this increase in amplitude you'll only get with upper airway obstruction and not with central sleep apnea. Unfortunately, we can't do that at the moment because our inpatient lab is shut. So we instead went for a repeat sleep study, and this is what we found. So clear upper airway obstructive snoring, inspiratory clicks at other points in time. And I think this just really highlights how useful it is to have the sound to be able to go back and listen in on these studies so that you can make a clear diagnosis. Next, we've got a patient who's referred to us with refractory hypertension, and I'm including this one because this is one of our research studies. So we used a Black Flash Plus so that we could use thoracic and abdominal effort bands, which we wouldn't tend to use as a standard in our clinical practice. Essentially, this patient has got refractory hypertension, so he's on 6 agents to try and control his blood pressure, but despite that, he still has elevated blood pressure. In terms of symptoms, he sometimes snores, but is not aware of any witness apnea, just wakes up once a night to go to the toilet. He tends to go to bed around midnight and wakes up at 6 AM. That's because he works as a chef and comes home late in the evening. And then therefore he'll often have a nap before he goes to work so that he's refreshed and ready. But again, Epworth sleepiness score is 2, and he's not falling asleep at other occasions. He's got a fairly extensive comorbidity, so diabetes, obesity, NAFLD. He's got on his echo, he does have some left ventricular hypertrophy, but his ejection fraction is normal and there's no suggestion of diastolic dysfunction. So he has a sleep study, as I said, with excellent recordings, good length of study. ODI is 20 and his AHI is 28. And his sleep study, I will play for you now. So I think his sleep study is quite tricky to interpret. He has what you can see across the page here. He's got frequent apneas, and they've been classified as central. And I think if you look at the abdominal and thoracic belts, you can see why. In that on the abdominal belt, there's a lack of effort. I think there is still some effort in the thoracic belt here on this occasion. Not so much here. This is probably more mixed. But I think the real value here of being able to listen into the sound is that there's a very soft but clear inspiratory click throughout the recording. So that I think is indicative of respiratory effort and ongoing upper airway obstruction. So whilst he has a somewhat mixed picture, there's certainly at least a large degree of upper airway obstruction here. And CPAP would then therefore be the treatment of choice, first choice for this patient. Can everyone appreciate those soft inspiratory clicks? Although they're quite, did they project through okay on the sounds? Good, okay. So he's again going to be going forwards for CPAP once he's finished our research study. Okay, so this is a final case of just showing how important I think the sound is in really illustrating the point of where you might not otherwise get the diagnosis from the numbers. So this is a 40-year-old woman. She presented to us with habitual snoring, witness apneas and sleepiness. She again had choking episodes, so fairly suggestive history of obstructive sleep apnea. She had a short sleep duration, so only sleeping for 5 or 6 hours a night, and was sleepy in the daytime. She was napping daily, sleepy whilst driving, and had a really markedly raised Epworth sleepiness score of 19. She's got a past medical history of Turner syndrome and has had cardiac operations in the past. Her latest echo showed a bicuspid aortic valve, but showed good function otherwise. BMI was around 36. So she went on to have a sleep study. So it's a fairly short duration on this study, but nevertheless enough for us to get a diagnosis. So she had 5 hours of recording. If you look at her ODI, this was low, and her AHI was mild. So not that impressive numbers. But then if I play you the study, you get a different picture. So again, that loud obstructive snoring, if you look through the tracings here in this study, you can see saturations. There are some desaturations, but these are not necessarily meeting a 4% desaturation criteria. There are large rises in heart rate in association with microarousals here, with increased ventilation, and then reduction in ventilation, either fulfilling the criteria of a RERA or a hypopnea. As I played to you, the sound is really, really very helpful in clinching the diagnosis that this is someone with either upper airways resistance syndrome or mild OSA. So I think what I wanted to summarize by saying was that I think that the current threshold-based approach that we have is very limited. And I think it's particularly when we have a treatment, our mainstay of our treatment, which works across the spectrum of severity of OSA. And I think, therefore, what we should be aiming to do with our assessment is to identify with a very good history whether someone has a clear history suggestive of obstructive sleep apnea, work out the impact that then has on their quality of life. With a sleep study, you can then look and see if the extent of hypoxia and whether someone is sleepiness and whether that might then contribute to risk of other outcomes like cardiovascular disease. But I think when you then are coming to interpret these difficult cases where the ODI and AHI may not be necessarily telling you the whole picture, the sound channel I find really invaluable in helping me to interpret a sleep study, in that it tells me whether something is obstructive or central, but also it can help identify RERAs and obstructive events which are not causing desaturations. So I wanted to end there. Happy to take any questions that anyone might have.
Thank you, Chris.
Hi there.
I just got one question. It's very specific, I'm afraid. Just that last patient you mentioned,
Yeah.
with Turner syndrome. Obviously, with that, they tend to have larger collar size, larger neck, slightly different upper airway anatomy.
Yeah.
With being aware of that, lead you more towards upper airway resistance or more towards obstructive? As a general and in that particular case?
More towards it being upper airway resistance or being obstructive sleep apnea. No, I think it could cause either. And I think that the two conditions really exist along a spectrum of severity anyway. So if someone with upper airway resistance syndrome was to have longer events because they weren't arousing from sleep so quickly, presumably as might occur with having had the condition for a longer period of time, you would imagine that they would eventually develop obstructive sleep apnea, particularly if they were to become more obese. So I don't think it would particularly point you towards upper airway resistance syndrome or OSA, but I think it's a well-made point in that Turner syndrome is a risk factor for obstructive sleep apnea due to the upper airway changes.
I've got a quick one.
Yeah,
I think it's not an engineer, but what could we take home if we can't just look at AHI as a nice crutch of what to do with a patient? Is there a nice, easy way to be able to quickly get through the sleep studies when you've got a stack of them on your desk and you've got something else to do?
So I think when I'm sleep reporting, I think there are some cases where it's very, very obvious. So you can look at simply look at the oximetry tracing. You can see that the referral information, and they will have completed a questionnaire by the time they see us. And with those two things, it's very obvious that this person has OSA. And then you're just going into the sleep study and trying to sample some of the events, listen to a few of the events to make sure that you've got things right in that assumption. And then those patients you can move through and be satisfied you've got the correct diagnosis quite quickly. But I think with patients whereby things are a little bit more grey, I'm afraid you just have to go in and listen to the sound and look at the study in detail to get the right answer.